Good morning, everyone. From Paris, this is a mini course on Kawasaki disease. It is a course that we have changed with difficulties from presence to virtual, but we are happy to collect cases from young residents from France and from Germany. We have now 30 participants, and we have prepared with the help of these very good colleagues, 6 clinical cases. I remind everyone that just as a meeting, also this mini course is being recorded and will be available to all participants even for 1 week after the meeting. I also remind everyone that this course will last 1 hour, and after this, the meeting will start, and that when the meeting will start, you will be in a different session. So remember at the end to close this session and open the next one. The course has been prepared with the help of myself, Rolando Cimat from Milano, and Dr. Teresa Gianni from Florence, who is co-moderating the course from Italy. We have 6 cases which will be followed by discussion and sometimes also a vote. So we hope that this course will be interactive, and therefore whoever has any comment or question, you have the tab on the right side, chat or question, as well as a tab which says polls, which I will tell you, explain when is the turn of voting. I call on stage the first speaker, which is Dr. Mohamed Nashawi from Stuttgart, who will present interesting case. Mohamed, the stage is yours, and you can describe your case.
Hello, good morning, everybody. Can you hear me, right?
We can hear you well.
Yeah. Okay. Good morning, everybody. My name is Mohamed Nashawi. I'm from Stuttgart, from Germany. It's my honor to present to you the first case and to discuss it with you. The take-home message of my case is in the title, which is Take the Complete History. Please, next. I would like to present this young lady. She's 3 years old. She came to our hospital and admitted because of fever since 4 days. She complained also of diarrhea, no vomiting, no abdominal pain. On the clinical examination, we noticed cervical lymphadenitis, bilateral conjunctivitis, and skin rash like you see in this photo. Also, strawberry tongue and palmar and plantar swelling has been noticed. We think of our differential diagnosis, and in top of the differential diagnosis come infections and, of course, Kawasaki disease. Please, next. We did our workup, and we could exclude these infections with PCR or with negative antibody, Epstein-Barr virus, measles, formillavirus, or the same as hantavirus, mycoplasma, adenovirus, enterovirus, also rotavirus. And in this pandemic, we excluded coronavirus and PCR on antibody. CBC showed normal results. She showed a high inflammatory parameter with high CRP and high ESR. Liver enzymes tests were also high, and the NT-proBNP showed high levels. We did ECG and echo, and it showed normal heart function. Abdominal ultrasound showed also no signs of serositis and no hepatosplenomegaly. With this sign and symptoms and with this workup, we diagnosed this patient to have complete Kawasaki disease, and we started her on IVIG and aspirin. And she improved after 24 hours with no fever, and the CRP decreased. And after 10 days of admission, she showed this typical build of Kawasaki disease, which is desquamation of the fingers, which is you see it in this photo. Please, next slide. When we go back to the history, the mother gave us a history of mouse outbreak at home 3 weeks before admission. Any idea of this information will change our diagnosis, or it will help us in the diagnosis? Please write in chat if you have any idea.
We have 1 minute for you to write anyone of the participants or in the audience if you want to suggest something. We give 1 minute of silence, and then we will resume after the chat if someone has any ideas. No one has any idea of what can change with this further asking? Remind that the title was Take a Complete History. So there is one question which says, what are the living conditions? Mohammed, can you tell if in this house there was anything strange, living conditions, I imagine social or any problem in the construction of the house?
They live above a restaurant. Because of that, there was this mouse outbreak, but there was no any suspicion of any other problems in the house.
And for Dr. Schwartz, maybe if you can write in the chat if there is any idea behind this question. Are you thinking of anything specific when you say the living conditions? Adrienne is typing, so let's hear. Maybe rodent-related disease. Mohammed, I think you can go on.
Good, then we go for the next slide. Yeah, we thought of leptospirosis, and we tested this in urine, which is the most specific test for leptospirosis, and it came positive. And like we see, there is a big overlap between Kawasaki disease and leptospirosis. The patient with leptospirosis can come with fever, arthritis, meningitis, diarrhea, hepatopathy, lymphadenitis, bilateral conjunctivitis, skin rash, and elevated CRP and ESR, like in our patient. But exclusively in Kawasaki disease, there is desquamation of fingers and oropharyngeal mucous membrane changes. And according to these last two signs, we diagnose this patient to have leptospirosis-induced Kawasaki disease. And it's important in such patients not to delay the start of IVIG, because it will prevent the subsequent complications. Thank you very much.
Adrienne, that was your good point, yeah. Because it was a rodent-related disease. There is another question for Mohammed. Are there other family members with symptoms?
No, there was nobody with the same symptoms.
Okay. So this case highlights the difficulties in the differential diagnosis, the importance of the history. Now, Dr. Gianni maybe will give you a few hints as take-home messages. Teresa. Differential diagnosis. Think about it, check it before treating. Can you go on with the next slide? Okay. I think we cannot hear, so there are several infections that you have to think about in the differential diagnosis. Moreover, drug reactions and other rheumatological diseases in the differential diagnosis. In the infections, you can see a list, not only leptospirosis, but rickettsial infection, such as in our case, and of course, all the viral infections that we are used to when we are dealing with febrile illnesses. Can you give the next slide? With regard to the measles, of course, first question would be the need the vaccination or not. And then there is also some differences between Kawasaki and measles with regard to the development of the rash, which is earlier in one case, later in the other case sometimes. And also, usually the measles rash starts from the forehead, behind the ears, and spreads downwards with the head to toe direction. and can tend to coagulations. Next slide. Also, the conjunctivitis might be a little bit different, with some sticky eyes in one case, and usually no discharge in Kawasaki disease. Next. This is some other hints for the differentiation between measles and Kawasaki disease. Of course, the slide is measles with the Koplik spots and runny nose in case of this viral infection, which luckily we see very little now because there is a vaccination. Next. Adenovirus is another important differential diagnosis. You can see with adenovirus the conjunctival injection, which has copious tearing and a foreign body sensation. Moreover, there are other differences in that this viral infection has only very rarely a rash. The lymph nodes are swollen bilaterally, usually. And then there is, of course, exudative pharyngitis, rhinorrhea, and cough. Next. What is the difficulties? We heard it already yesterday, is that sometimes it is difficult to differentiate if the infection is the cause of the symptoms or if the infection is triggering Kawasaki disease. And we have seen more than once even coronary abnormalities in infections by herpes or Coxsackie or even adenovirus. So the clinical decision sometimes is difficult on whether we should start a treatment for Kawasaki disease or we can wait and see if this is only a viral infection. Sometimes the laboratory tests are useful, especially when we can get samples for PCR for the different viruses, for adenovirus, for example, and nasopharyngeal sample is useful. We have the toxic shock syndrome, which is a toxigenic strain of Staphylococcus aureus, and this is also a differential diagnosis with Kawasaki disease. You can see in the slides which are the differences in this toxic shock syndrome. Usually it is older children. The rash can give erythroderma and desquamation. You can sometimes have ulceration in the mucosa, also in the vaginal mucosa in the females, and it is usually very severe with hypotension and often multi-organ failure. The laboratory test will help in that there is decrease in platelet count and increase in liver and kidney function. Next. The Stevens-Johnson syndrome is not very difficult to differentiate in its full-blown picture, but sometimes there are forms that can give difficulties in the differential. In this particular form, there are this target lesion and mucous membrane involvement that is really, really prominent, as you can see in the photo. Sometimes with erosions which are very painful of all the mucous membrane. And the purpuric macules can have necrotic centers with overlying blistering. Next. So the red flag to differentiation Kawasaki with other forms, in particular infection. Remember that exudative conjunctivitis, exudative pharyngitis, ulceration in the mucosae, a bullous or vesicular rash, a generalized adenopathy, or visceromegaly, in particular splenomegaly, would be against the diagnosis of KD, and you have to think of alternative diagnosis. Next. I now invite on stage Dr. Robin Keshish, who will introduce and explain the second case, which is entitled "A Rash Can Hide Another One."
Good morning. Can you hear me?
Please, Dr. Keshish. Okay. Can you speak?
Yeah. Okay. Good morning, everyone. My name is Robin Keshish. I am a resident in the pediatric rheumatology department of the Bicêtre Hospital in Paris, and I am going to present you a clinical case called "A Rash Can Ride Another One." Next slide, please. So we are going to talk about the clinical case of a 15-year-old child of Chinese origin without any notable history and up to date with his vaccination. He initially presented a plateau fever, which was well tolerated in a context of odynophagia. A rapid strep test at D0 was negative, but became positive at D4, leading to the introduction of amoxicillin. When the fever persisted at D8, amoxicillin clavulanic acid was introduced. At D9, a rash affecting the large fold was observed, consisting of a pruritic erythematous papillopustule. And in this context, the child was hospitalized at D12 for explorations. Biologically, the CRP was 235, there was hyperleukocytosis at 25,000, and hepatic cytolysis at 4 times the normal. The blood culture and CBEU were negative. Abdominal ultrasound and chest X-ray were normal, but the cardiac ultrasound showed hyperechogenic right coronary artery, suggesting the diagnosis of Kawasaki disease. Next slide, please. After initial treatment with ceftriaxone for 5 days in the hypothesis of an infection, it was decided to treat the patient with intravenous immunoglobulin at 2 grams per kilogram combined with antiplatelet aggregation dose aspirin. After 2 failed infusions of intravenous immunoglobulin and the persisting of fever, the patient was transferred to our department at D20 with the diagnosis of Kawasaki-like disease. Next slide, please. At this time, the child had 1 or 2 peaks of fever in the morning and evening, which were generally poorly tolerated. He was asthenic with a loss of 5 kilograms since the beginning of the story, and the rash seems to regress progressively, evolving toward the fine desquamation and the clinical examination showed no joint damage, no lymph nodes, and no hepatosplenomegaly. Concerning complementary exam, a skin biopsy of the lesion showed an aspect of leukocytoclastic vasculitis compatible with the diagnosis of an acute generalized exanthematous pustulosis. No infectious cause was found, and there was no autoimmunity or argument for a tumor cause. Finally, cerebral imaging did not find anything of cerebral vasculitis. At D23, the diagnosis of acute generalized exanthematous pustulosis was retained despite the prolonged evolution due to the probable causality of penicillin intake at the beginning of the history, and a treatment by topical corticosteroid was initiated. However, at D25, the evolution in the department led to the appearance of a new maculopapular, migratory, and pruritic rash affecting the trunk and roots of the limb, associated with myalgia and arthritis of the right knee, documented by a joint puncture and revealing no germ. The entire clinical picture associated prolonged fever, evanescent skin rashes, inflammatory arthritis, and the absence of any argument of infectious, autoimmune, or toxic etiologies led to the final diagnosis of Still's disease. The child was finally treated by corticotherapy with spectacular efficacy on the fall of fever and on the normalization of the biological inflammation within 24 hours. Now, the patient relapsed due to the decrease in corticosteroid and was finally treated effectively with Kineret from 2013 to 2018 with a persistence of no symptoms since. Thank you very much.
Thank you, Robin. This is also another very interesting case, and it highlights some differences, again, in the differential diagnosis. In this case, the differential diagnosis is between systemic onset, JIA, and Kawasaki disease. And you can see some photos of different types of KD rash. Maybe one message could be that it is extremely rare to have a psoriasiform rash in KD, and that if you have a bullous rash, a vesicular rash, or a petechial rash, you should think of an alternative diagnosis. This is why the red flag. If there are no other comments in the chat, as I can see, we can move on to the next case. And I invite Laure Genic from Lyon to introduce her case, where we will also have some votes. Laure, the floor is yours.
You can hear me, right?
Very well.
So, hello everyone, my name is Laure Genic. Let me introduce you diagnosis and treatment pitfalls. Next slide, please. We report here a case of a 4-year-old boy who developed typical symptoms of Kawasaki disease, like persistent fever, mucocutaneous and lymph node involvement, associated with diarrhea and pericarditis. 3 immunoglobulin cures did not prevent coronary dilatation, with a Z-score for the interventricular artery and right coronary between 2.5 and 5. Then, he developed a macrophage activation syndrome at day 15 after fever onset, despite the use of anakinra. So, what treatment do you suggest for this MIS? Answer A, cyclosporine alone. B, steroid pulse. C, tocilizumab 12 mg per kilo per 2 weeks. D, infliximab 6 mg per kilo per 4 weeks. E, rituximab. You can
now, if you go on the tab which says polls, you will see that the answers are written. Please click on your preferred answer and submit your vote, and we give 1 minute for your vote. Okay, we had several people voting, and
okay, so
some chats on this. Some chats is also appearing. So in the chat, there is a question: during the 3 doses of steroids, did not receive steroids?
No.
The answer is no.
Only IVIG.
The results of the polls is the following: cyclosporine alone, 0. Most of the people voted for steroid pulse, 90%. And then there are a few answers on infliximab and rituximab. We will talk later about macrophage activation syndrome in Kawasaki disease. We have another full case, but actually what was done, I imagine, and what we consider the correct answer is a steroid pulse. We can go on with a slide which says steroids are the first line of therapy for MAS, but cyclosporine can be considered in association. And then there are other promising therapies which we can discuss later during the other MAS case. Laure, can you go on with the following slide, please?
Yeah. Then the evolution was marked by refractory Kawasaki with persistent fever, hepatomegaly, for which he received infliximab. And at day 55, he developed a polyarticular arthritis and elevated acute phase reactance. So what treatment do you suggest for this polyarthritis? Answer A, anakinra or canakinumab. B, steroid pulse plus methotrexate. C, tocilizumab. D, infliximab. E, rituximab. You can
go in the polls and you can submit your vote just like before. People are voting very quickly, and actually here we have some comments which say anakinra, which is the answer A. Please vote in the polls, not in the chat. The answers here are split because we have about half, 44%, tocilizumab, 37% anakinra, 16% steroid pulse plus methotrexate, and 5% rituximab. So the answer of this case was C, C is tocilizumab. Why not anakinra? Because the initial MAS appeared under anakinra, so it could be a possible toxicity. Steroid pulse was already done, so also answer B has not been considered. I do not know who is the one who keeps adding rituximab in the answers, even in the first answer, because rituximab, to my knowledge, has not been used in this occasion, not for MAS, not for polyarthritis related to KD. So this was treated first with steroid pulses and then with tocilizumab. Last slide. Can you move? Okay. So this is again with the poll. What would you retain as a final diagnosis since the disease evolves into a chronic polyarthritis? And here there are 4 answers that you can read. I do not need to read the answers. Please again vote on this poll, and maybe Laura can, once I read the vote, can comment on the results. So, Laura, the vast majority answered A. The patient has systemic onset juvenile idiopathic arthritis. A few persons wrote that the diagnosis is atypical Kawasaki disease with arthritis. And then there is also a few persons who said that a search for a LAC1 mutation is relevant. No one said that the virus-related infection can be discussed. You want to say a few words on this polls?
Yeah, the right answer is AC. The patient has systemic onset juvenile idiopathic arthritis, and in this context, a search for LAC1 mutation is relevant.
So actually, what has been said is a little bit different from the answers. Maybe can you say a word on this answer C that very few people answered? Why? Can you tell in 1 minute what is LAC1 mutation and why would it be relevant for those who are not in the field, just as you are in Lyon?
Yeah, the patient is 4-year-old, so he's really young, and LAC1 mutation can develop autoinflammatory disease. So in this context, with atypical symptoms, we have to search this mutation.
Okay, so this LAC1, for those who are not familiar, was a mutation which was described in Saudi Arabia at the beginning in families, consanguineous families with a systemic form of arthritis, and this is why it can be searched in other selected situations. Thank you so much, Laura. That was very interesting as well. And thank you to all who voted. Can we go to the following slide, which is a take-home message on macrophage activation syndrome that this child developed as well as the previous one. We know it from systemic onset arthritis. It is also present in KD, but we do not know the frequency. Some people say it is very low, 1 to 2%, but it has not been studied very thoroughly. It usually follows KD onset, but sometimes it can be simultaneous, and it can be very severe also with a high mortality if not recognized and treated properly. Next. What are the hints that KD can have MAS? You have to consider occult or subclinical MAS, especially if there is some systemic features such as splenomegaly, and when you have some laboratories which are not consistent with KD. I remind that KD, except in the initial phase, is thrombocytosis, while if you get low platelet count, increase in ferritin, and in liver enzyme, you might consider MAS. And in some cases, you also need, especially in the very, very young, to look for the genetic forms of MAS, which is HLH, hemophagocytic lymphohistiocytosis. Next. These are the diagnostic criteria of HLH that sometimes are used, but mostly for clinical research and for classification, not so much for in the clinical field when you have low platelets and the clinical deterioration. You have to think of MAS even without all these diagnostic criteria. Next. What about the treatment? As in the poll, most have used corticosteroid, which is first line. Cyclosporin can be added, and there are some reports also of cytolytic therapies such as etoposide and other chemotherapies. Next. The anakinra has been used for MAS, even if in this case it is interesting that MAS started on anakinra. So it is just as in systemic diarrhea, it is sometimes confusing because this complication can be both triggered and treated with the same drug or by the same drug. There are some new treatments that have been proposed, such as interferon gamma neutralization or the IL-18 blockage. Next. I now call on stage after this case Dr. Camille Mosser from Le Kremlin-Bicêtre, who will present her case of immunoglobulin-resistant Kawasaki disease.
Good morning, everybody. Can you hear me?
Very well.
Okay. I'm Camille Mosser, pediatric resident at Bicêtre Hospitals. I'm going to talk to you about a case of immunoglobulin-resistant Kawasaki disease. Please, next. The patient is a young 13-year-old child. He was born to unrelated Angolan parents. His normal weight and side with no medical past. His story began with episode of nausea and vomiting, quickly followed by a fever around 39 degrees at day 2. At day 5, he developed a rash and a left painful lymphadenopathy and nasopharyngitis with enlarged tonsillis. He couldn't eat enough, so his parents took him to the emergency room. After practice 2 negative rapid streptococcus tests, he finally came home with the diagnostic of viral angina and a symptomatic treatment. 2 days later, 7 days after the onset of symptoms, fever was still present and degradation of general condition. Bilateral conjunctivitis, cracked lips, and strawberry tongue appeared, and his parents went once again at the emergency room. The blood test practiced showed inflammatory syndrome with C-reactive protein at 55 milligram per liters, no hyperleukocytosis, and infectious standard blood test negatives. In this context of persistent fever with lymphadenopathy, rash, cheilitis, and strawberry tongue, we diagnosed Kawasaki syndrome and hospitalized the child. Please, next. When he arrived in the unit, he had fever, tachycardia, without cardiovascular symptom. In accordance with the recommendation, we quickly started a treatment with aspirin and immunoglobulin at the dose of 2 grams by kilograms. After a day of apyrexia, despite infusion of immunoglobulin, the fever came back with uncomfort and persistent rash. There was no argument for myocarditis. Troponin was normal, and we performed a cardiologic ultrasound at day 13. It showed coronary dilatation of the left common trunk artery without right coronary abnormalities and normal cardiac function. Next, please. Because of the persistent fever and the coronary damage, we decided to include him in the protocol Kawasaki. The aim of the protocol is to evaluate the effectiveness of interleukin-1 in the management of Kawasaki disease. We gradually increase the dose of this anakinra, and he had apyrexia after 3 days of treatment. Pharyngitis and polyadenopathic decrease in the second time. Inflammatory syndrome decrease and after reaching a maximum value of CRP at 76 milligram on day 16, and cardiologic ultrasound control was normalized at day 18. Please, next. After 20 days of support, he came home. During the follow-up, we continued aspirin treatments and daily subcutaneous anti-EL1 administration without recurrence of fever. When we stopped therapeutics, there was no recurrence of fever, and cardiologic ultrasound remained was normal. Thank you for your attention.
Thank you, Camille, very much. Can we have the next slide? I think there is some take-home message. Next. This is related to the 15% of cases that do not respond to the first IVIG, i.e. when the fever persists or comes back. Next, there are some treatments for the resistant cases. Unfortunately, we do not know who will be resistant beforehand because, as you all know, both Kobayashi, Sato, Egami, and other scores work very well in Japan and Asia, but are not validated for Western population. Together with Isabelle Conepo and Marianne Pilar and others, we have tried to suggest a European score, the Kawanet score, which will need to be validated. Next one, this will be very useful in order to start with a more potent treatment. American Heart Association in the last guidelines suggests several agents for the resistant cases, but they do not suggest any specific one. They are not in order. They are just listed. There are some trials either finished or ongoing, and hopefully in the next future we will have more answers. With regard to anakinra, there are 2 studies. Professor Conepo's study has just been published. It's a phase 2A study on failed to first IVIG, and the California San Diego study, which is not finished, the ANAKID, is only for patients with coronary artery abnormalities, and we are waiting for those results. There are other treatments. One study will soon be published on infliximab. I now invite on stage Dr. Zwiebler from Ulm, Germany, who will explain what these cases are that they have seen in Germany of atypical and severe Kawasaki disease into infants. Beatrice Zwiebler, if you can come on stage and present your cases. We are waiting for Beatrice. In the meantime, please put the next slide. I am giving Beatrice a few minutes to come on stage. hopefully. I think we can move on. Oh no, maybe she's coming. Okay, Beatrice is here.
Hello, I hope sound is working.
Sound is working, yes.
Okay, and the picture hopefully comes as well. I'm just starting. I'm Beatrice Ziefler from Ulm, and I'm going to present 2 infants with atypical and severe courses of Kawasaki disease. And they had an overlap of HLH and Kawasaki disease at onset. So the first child, 3 months old, he presented at hospital at day 1 of fever. There was no focus find, but elevated CRP, and we started with antibiotics. Then he developed Kawasaki disease, so we started with immunoglobulins and anticoagulation and also prednisolone. And also he developed a secondary HLH. So dexamethasone was started and also anakinra. But unfortunately, in the echocardiography, we saw a dilatation of the coronary arteries. And they got bigger and bigger. We increased the anakinra dose, but nothing changed. And he still had fever. And on 29, we saw in the echocardiography that he had a myocardial infarction. The coronary aneurysms, the biggest was 1.5 centimeters big. So he had a myocardial infarction. And despite of local and systemic thrombolytic treatment, he unfortunately died on day 30. So this was a tragical case. This is the first case, and next slide, please. So this girl is 2.5 months old. On day 1, she developed fever, and they presented us at hospital on day 2. She had signs of HLH, including beta-cytopenia, fever, elevated CRP, ferritin, and elevated soluble IL-2 receptor. And she also developed signs of Kawasaki disease. Primarily, HLH was unlikely because the NK cell degranulation was normal. And the HLH was controlled with dexamethasone, so cyclosporine A. Echocardiography later revealed coronary aneurysms, but they were stable. We could discharge her on day 26, and now she's 3.5 years old, and she still comes to hospital for control, and she has persistent coronary aneurysms, but she's feeling good and she's going to kindergarten.
Thank you very much, Beatrice, also for these 2 very severe cases. Anyone has any comments or questions for Beatrice in the chat? These comments can highlight maybe the fact that the very young, in this case 2 months, 3 months old, are frequently the more severe. Sometimes it is for the more difficult diagnosis when you have such a very young child. Sometimes there is a problem of differential and of incomplete forms. There is a question for Dr. Ziebler, for how long to be kept on anakinra? Dr.
So
Ziebler,
we started on day 11 when CRP and ferritin was still rising. We started on day 11 until day 30.
From day 11 until day 30. So the anakinra was kept for 3 weeks. And then another question, any genetic studies have been performed?
No, we didn't.
So probably the question relates to what I said before, that in the very, very young, in the toddlers, the HLH, familial HLH would need to be excluded, and therefore the genetic studies relate to this type of mutations. The bell is telling us that it is 9 o'clock, and I thank also Beatrice for the nice cases. We will move to the last case by Dr. Lena Malbrunot from Robert Debré. And I invite Lena on stage to present her case.
Good morning, everyone. Do you hear me properly?
We do.
Yeah, okay. So firstly, I'd like to thank you, my fellow comrades, for their brilliant presentation. It was really interesting. Can you move on to the next slide, please? So I'd like to present to you the case of Saif, a young boy, aged 9 years and a half, with no medical, personal, or familial history. And his story that concerns us today begins on the 20th of November, when he began to have fever associated to abdominal pain. His general practitioner performed 2 exams, which were urine test, which showed an aseptic leukocyturia, and also, since we are in 2020, he also performed a PCR for SARS-CoV-2, which returned negative. He tried 2 lines of antibiotics, which were obviously unsuccessful. Can you move on to the next slide, please? And yeah, they were unsuccessful since when came the 3rd day of December, he was on his 6th day of fever, and he presented with hemodynamic and respiratory failure, which necessitated oxygenotherapy and fluid replacement, and also the beginning of antibiotics with meningeal pathology by the emergency medical service, so at home. And when he arrived in the emergency room of Robert Debré, he was hopefully in a steady cardiovascular and respiratory state. He presented with a very stiff neck, very large cervical lymph nodes. He was very uncomfortable, very grumpy. He had cheilitis. He had a bilateral conjunctivitis, and he also had a cutaneous rash, absolutely aspecific. I'm afraid I don't have any photos to show you, unfortunately. So here you've got the first line of his biological exams. So they showed basically an increase of leukocytes at 14 giga per liter, and mostly neutrophils. He also had a very high fibrinogen at 8.3 grams per liter, and a very high CRP at 258 milligrams per liter. So the first question I will ask to you, but I don't think we can spend much time on it, what are your first diagnostic hypotheses? But I think we've already mentioned all of them already, so I suggest we move on to the next slide, maybe to go a bit quicker. Can you move on to the next slide, please? Yeah. So if you want, you can write your diagnostic hypothesis in the chat.
We will leave 1 minute for any ideas that can be written, or any questions or any ideas that can be written in the chat for 1 minute. Okay, there are several answers which are similar. There are the answer which says typical KD, and the answer that talk about TIMS, also called MIS-C, that probably you all know. Please move to the next slide.
Thank you. So, of course, the first things we wanted to eliminate was a severe infection. So we checked for meningeal infection. We tried to do 2 lumbar punctures, but unfortunately we failed. he was too uncomfortable, he was too stiff to perform them correctly. We also checked, we checked for cervical adenitis, since he had very stiff neck and big lymph nodes. We performed a cervical CT scan, but we showed only large lymph nodes with no signs of local infection. We performed as well an abdominal ultrasound to eliminate any abdominal infection. There was nothing on that exam either. We did an X-ray, which was as specific. Blood and urine cultures were negative. And so we moved to inflammatory etiologies, as you suggested. So Kawasaki, why not? But he's a bit old for that. Or indeed a PIMS, so that is pediatric inflammatory multisystemic syndrome associated to COVID. So that's why we performed as well a serological test, even though we didn't have any recent COVID contact when we asked his parents. We performed a serological test for SARS-CoV-2, and which returned positive for IgG. And for all these inflammatory causes, we also performed ECG, troponin, BNP, and echocardiography, and all these exams were normal. So next slide, please. So we concluded to PIMS without myocarditis at diagnostic. We treated him as so with corticosteroid, high dose, 1 milligram per kilo every 12 hours, associated to IVIG, 2 grams per kilo during 36 hours perfusion. We also started a prophylactic anticoagulation since his fibrinogen was very high, and we started as well a treatment with aspirin. He very rapidly improved since the fever ceased after 2 days. We were able to stop the oxygen at D4 after the beginning of treatment, and he had a negative CRP at D6. So he quite evolved on a good path at first, and we were able to begin to decrease the corticosteroid as soon as D7. So dividing his dose by 2, and then 5 days later again by 2. So at day 12 of his evolution. Next slide, please. So what is interesting about this child is that he had a peculiar evolution on the cardiovascular side, since, of course, we control his ECG on a daily basis, and his troponin remained normal. But when we routinely control his echocardiography at day 16, after the beginning of the treatment, we found 3 big coronary aneurysms. So that's where we decided to begin a therapeutic anticoagulation to change our therapy. And just at that point, before we started the therapeutic anticoagulation, we decided to perform a lumbar puncture, since we had not been able to do them at diagnostic, and since he had been presented with headaches for about a week before the control echocardiography. So we did this lumbar puncture at that point, and it revealed an aseptic meningitis. So he had a very complicated evolution for him. And so when we changed his therapy, when we added the anakinra, and when we increased again the corticosteroid therapy at 1 milligram per kilo every 12 hours again, he very rapidly improved, and the headache ceased. And so yeah, good evolution. And that's what you can see here on this slide, which shows both his symptomatic evolution, the treatment, so with fever and headaches. You see that headaches beginning here, and that's when we did the lumbar puncture, just before putting Kineret and beginning the therapeutic anticoagulation. And what is interesting here as well is that you can see his biological evolution with a CRP that became negative very rapidly as soon as day 6 after the beginning of the treatment, whereas the ferritin remained very high, and we can even see that just before we discovered the coronary aneurysms, it reached a peak. So maybe the ferritin was more useful for this child to monitor the systemic inflammation than CRP, obviously, or at least for him. And then he evolved on a good way, a good path after the introduction of Kineret. Next slide, please. So yeah, this case is finished. Just to tell you, we kept the anakinra for 15 days and for this child. And so here is a slide which shows 2 figures extracted from an article published in the in last August 2020 by Marie Pouletti, and which show well, here you can see the main differences that have been recorded between typical Kawasaki syndrome and the PINs associated to SARS-CoV-2 infection. And the importance as well of gastrointestinal signs that were present for this child. So I read the question, why did he continue to have coronary?
There are 3 chats. We have only 4 minutes, and I have take-home messages for teams. But if you can really answer quickly, why Coumadin with the carbs this cause? Did he continue to have coronary aneurysm, and why not steroid pulse? You can write your answers in the chat, and in the meantime, I can give just a few messages to close this course, highlighting the differences between MIS-C and KD. All these slides are available because, as I said, the course is recorded and will be available even after the meeting, so you will have time to read them. In particular, these are the ACR publication of the overlapping clinical features of the 2 conditions. Next. The differences, especially between the 2 conditions, and I remind the main ones being ethnicity, age, and clinical features, mainly more GI and neurologic symptoms. With regard to treatment, treatment is similar with IVIG. Next. Glucocorticoids with some specific recommendation when to use low dose, when to use high dose. Next. Anakinra, of course. Next. This is high dose anakinra that has been published from several centers. Next. This is some tips on how to give IV anakinra, because there are some tips that need to be known before giving such IV treatment that we used to give subcutaneously. Next. And of course, antiplatelet and anticoagulation. Next. I think that the last one is on possible novel treatments, which is on the JAK inhibitors. I think that, well, this is an algorithm by the ACR on treatment of MIS-C. As I said, there are some chats that we do not have time to discuss, but I am sure that Dr. Malbruno will have time to answer to all these people. It is 9:14. We have now almost 70 participants on stage, and I would like to close this course, hoping that it was useful. We had many interesting cases, we had discussion, we had votes. I thank the participants, I thank especially Dr. Gianni, who helped so much in the preparation of these cases, and was moving all your slides while you were doing next and next and next from Italy. It is 9:15. We will have only 1 minute to close this session. I remind you to open the different session of the meeting, which will start in 1 minute. If you have any comments about this course, please send to the Secretariat, to Alpha Visa, who will forward it to us, and we hope to be able to repeat it in the future, hopefully in presence. Thank you, everyone. Thank you, Teresa. Thank you, Isabel, again, for having the support, and also Alpha Visa for helping in this difficult situation. It was not easy to change a physical interactive course to a virtual one. See you very soon in the other session to open the Congress.
Goodbye to everyone.